This is the problem pre-ACA. It gets a little better post-ACA, and that's why I show it to you. But pre-ACA, this is the increasing costs over time over a 70-year window. The costs just keep going higher. There's a slight undulation here. It's the demographic bulge of the baby boomers coming to the end of their boom, and the boom, and the boomlet beyond. But that's all it is just a little undulation. That's about it. And then the costs just continue going up. This is the small tax that comes out of our paychecks, 2.8% every month, 2.9%, 1.45% out of your paycheck, and then your employer matches at 1.45%. And this tiny little gray area here is the sum total of the trust fund that's accumulated over the last 40 plus years, right? So what does the healthcare reform do to this? It's a reduction in payments to private health plans. It's a reduction in payments to hospitals, because hospitals will no longer have as many uninsured people, so they don't need to get what are called disproportionate share payments for the indigent and poor. And it's encouraging bundled payments and kind of incentive reforms around providers. That a lot of us realize that the incentives around healthcare have really been to just do as much as possible, because I, as a radiologist, make more money if you do more imaging studies, and the hospital makes more money if we have more admissions, and the gastroenterologist will make more money by doing more scoping, and nobody's really actually making more money if the patient outcome is better. We're making more money if we do more, and that's the way our system is. And so there's a lot of thought that with bundled payments, we might have some real savings. There's also some concern, though, that the absolute savings are going to be as huge as some have promised or hoped for. Certainly, when you talk about it anecdotally, it sounds great. The evidence is not as strong as you would think that we're going to truly save big money from this, but we can only hope, right? And then you have this Independent Payment Advisory Board, which is another little political hot potato, because built into this act was this independent board to advise Congress, not even advise Congress, but basically force Congress to cut payments to providers and to reform the way Medicare is delivered if they don't meet certain cost targets over time. Now, one thing it is not, and this is starting to get to the separating facts from fiction. One thing it is not get to make any decisions about cost effectiveness. It does not get to make any clinical rationing decisions. It's not to say that there weren't people that wanted this, but as soon as Sarah Palin talked about death panels, any last vestige of doing anything that was evidence-based, cost-effective medicine was thrown out of this bill for fear of its political implications. So the IPAB has no ability to impact clinical care, except that if it reduces payments sufficiently to certain providers that they may not provide care, which is at least a legitimate possibility out there. And it also, in terms of cost, it also removes the indexing of Part B, since the Medicare Modernization Act of 2003, had income-related premiums. And we should all be so lucky that we should have to pay the income-related premiums because we should all be making more than $80,000, $90,000 in retirement. But those original thresholds were set and indexed to wage inflation, so that only about 4% of the population would have to pay these income-related premiums. They've taken that out from 2011 to 2019, which means that with inflation, those numbers will start hitting more and more of the upper middle class over time. And if they adjust that even more, you could see that income-related premiums could even hit the entire population over time. So that has a huge budgetary impact. I mean, you could answer for yourself whether you believe it makes sense or not. I, for one, actually do. I think the thresholds are set at a level that people can afford to pay more into the Medicare program. And this is just to remind you that Medicare Advantage, the private health plans, are 25% of the overall Medicare population right now. And relatively flat at the present time, but still a hefty number of people are enrolled in these private Medicare plans. And the revenue changes are as important, if not more important, in terms of funding this bill and helping with Medicare. So previously, as you know, your payroll tax for Medicare is 1.45%, your employer matches it. No limit on the income that this applies to, but it has to be quote, earned income. So if you're paid $10 million a year in salary, you're paying $290,000 a year in Medicare taxes. And if you're making $10,000 a year in salary, you're paying $290 a year in Medicare taxes. Both people get the same Medicare Part A at the end. The money flows into a trust fund, and it flows out for anything that a doctor says is medically necessary in the Part A program. So what is the big change with healthcare reform is that this is now modified for wealth, so that for high-income individuals and families or couples, starting in 2013, which is just a couple of months from now, you get a small tick up in this, 3.8% from 2.9. I say it's small, it's consequential, right? I mean, I'm not going to say it's not. It's a very meaningful tax. The reason why I say it's small is that this is really consequential. You know, I hope for the sake of you that it affects some of you in this room, but you know, if you're Mitt Romney, it's a 30% tax increase. 30% tax increase. Because all of his and I'm not picking on him, I really am not. I'm just using him as because everybody knows the example right now. All of his income is, quote, unearned income. It's capital gains, interest income, and dividend income. He's admitted to having this rate of 11 or 12%, right? This applies directly to him, 3.8%. So he goes from 11 or 12% up to 14.8 to 15.8%. That's an enormous tax increase. And on, you know, private equity investors, venture capitalists, others that have carried interest for which a large amount of their income is in capital gains and similar, this is an enormous tax increase. So I just don't want to diminish that. And I think
this impacts realized return on realized.
Correct. But it's whatever you're paying capital gains tax on now. Whatever you're paying capital gains tax on now, this applies to. Whatever you're paying dividend income that you're paying a lower, I don't even know what the rate is. Is it 10 or 15 right now?
15. It's
15? So you know, you're paying 15 now, it goes up to 13.8 basically with this. And the other thing that is not mentioned in the press at all, and again, you know, for those of you that at this point think that I'm too much of a Democrat partisan, this will shift you a little bit. This is the unheard thing. This is a huge tax on the middle class over time because these numbers are not indexed. So you factor in inflation over the next 30, 40, 50 years. If we have high inflation for just a few years, it'll happen very quickly. This will be the federal poverty level one day, right? I mean, it may seem absurd to you right now, but it will be. That's what inflation does. So once you factor that in, it means that these taxes are not just on high-income individuals. They will apply to everybody over time. So it is a little bit duplicitous to say that, you know, this tax is only on wealthy individuals, because by not having indexing in it, it will apply to everybody over time. And that's why the income rate on this slide goes up so nicely. It's why we actually narrow the gap between costs and income so very significantly, because of the lack of indexing and because we're getting to a lot more income over time. And the cost rate comes down over here primarily because of the Medicare Advantage cutback in spending and the reduced dish payments, and out here potentially due to pixie dust, because we're hoping that hospitals and health plans and everybody's going to somehow work together, and we're going to come up with more cost-effective ways to deliver the same type of care. And there's every reason to believe that we could accomplish that, but it's also possible that it's not going to happen, and that at some point this part of the slide does keep going up this way, and we still have a big gap. But even if you believe all of this is going to work out, even if you believe nobody's going to pull back on these tax increases and nobody's going to cut back on the payments that are being reduced to health plans, you still have a gap in just a decade from now that still remains to be filled in the Medicare program. So it remains a problem that we move forward with.